Hello, my name is Zehra Haider, and I'm an assistant professor of medicine at the Barbara Davis Center and a member of the American College of Diabetology. And today I'll be talking about disordered eating behaviors in diabetes. Now, if you've ever had a patient with diabetes whose A1C just doesn't make sense despite doing everything right, this talk is for you. Disordered eating behaviors are far more common in diabetes than we often realize, and many of us are caring for these patients without knowing it. So today, my goal is to give you a short, practical framework so you can spot it, screen for it, and intervene confidently without feeling like you need a psychiatry fellowship on the side. I want to help you recognize these behaviors earlier and feel more confident about what to do next. I have no financial disclosures. So I'll briefly review definitions so we're all on the same page, why this matters clinically, what we know about prevalence. Then I'll focus on warning signs, screening tools, practical next steps. This is meant to be very practical, things that you can take back to clinic tomorrow, because as a clinician, action points are what matter to me. So definitions. When we talk about eating disorders, we usually think of formal DSM diagnoses. But disordered eating behaviors, or DEBs, as I'll be referring to them, are more common, often subthreshold, and still clinically significant. In diabetes, we see unique patterns. Insulin omission for weight control, sometimes called diabulimia, and you'll often hear that term, even though it's not a DSM term, deserves special attention because it's extremely common. It's very dangerous, especially in patients with type 1 diabetes, and often wrapped in shame. Insulin manipulation can be considered a disordered eating behavior when additional insulin is taken to permit eating or a dosage is restricted to control weight. We also see binge eating disorder, especially in type 2 diabetes, and extreme restriction driven by fear of hyperglycemia or weight gain. So many patients won't meet formal criteria, but the outcomes are still serious and can increase risk of complications like retinopathy, neuropathy, and nephropathy. So why does this matter? This matters because these behaviors are common and easy to miss and affect our patients' quality of life as well as long-term morbidity and mortality. The ADA now recommends routine screening, yet many of us don't do this consistently. DEBs affect A1C, increase DKA risk, worsen quality of life, but often hide in plain sight. So your patients may look very engaged in care while they're quietly struggling. As far as epidemiology is concerned, we'll be talking about type 1 diabetes first. So about a quarter of people with insulin-dependent diabetes report disordered eating symptoms. Now, this figure also includes type 2 diabetics. But adolescents and young adults with type 1 diabetes have a 2 to 3 times higher risk of eating disorders compared to peers without diabetes. And intentional insulin omission for weight loss is reported in about 1 in 10 people, especially women. Disordered eating is not just a type 1 issue. In youth and young adults with type 2 diabetes on insulin, the prevalence may be as high as 50%. Think about that. Half of our younger patients in that category of insulin-dependent type 2 diabetes have disordered eating habits. More than a quarter report behaviors like skipping insulin, vomiting, or misuse of diet pills and or laxatives. Binge eating rates can reach 26% and correlate with a higher BMI, depressive symptoms, and worse glycemic control. So this isn't rare, and it isn't limited to one diabetes type. Why does diabetes raise the risk? Well, there are patient factors and provider factors. For patients, there's dysregulated hunger and satiety, which is often related to diabetes treatment, either with insulin or weight-promoting oral anti-diabetic agents. There's a fear of hypoglycemia. There's also appetite swings related to glycemic variability. For type 1 diabetics, especially, it's all about numbers all the time. The focus on counting carbs, measuring doses, watching blood sugars go up or down. It can really trigger those disordered eating behaviors. Patients with pre-existing mental health disorders like depression and anxiety are also at much higher risk. Fear of hypoglycemia can limit exercise. So when you add weight talk to the mix, you have a recipe for trouble. On top of that, there are provider and or clinician factors. Our weight-focused messaging, while it's not malintentioned, can often trigger these behaviors. There's infrequent screening for diabetes distress, and there's a push for perfectionism, which we're all trying to do as part of having best outcomes, all play a role. So when you look at it this way, these behaviors often make sense. These are the clues that many of us recognize. You may have an unexplained rise in A1C, wide glucose variability, recurrent DKA, missed insulin doses, lost pens, extreme diet restriction. There's always historical clues or a history that doesn't quite add up. And remember, if you're feeling frustrated as a clinician, that's often a signal, not a failure. The ADA now recommends routine screening for disordered eating in both type 1 and type 2 diabetes. So you should screen at least annually the first time you see a new patient in clinic or anytime there's a change in disease, treatment, or life circumstances. And this is part of the standards of care in 2025. And this is where many of us struggle. But keep in mind, screening is not labeling, it's opening the door to conversation. There's a couple of screening tools that are available for clinicians. The Diabetes Eating Problem Survey, or the DEPS-R, is a 16-item diabetes-specific screening tool for adolescents and adults with type 1 diabetes. It assesses eating behaviors, insulin misuse, compensatory behaviors, and takes about 10 minutes to complete. The DEPS-10, which I'll go over in a couple of slides, is a shorter option that can work very well for busy practices. Now, these can often be completed in the waiting room or through the patient portal as part of a pre-check-in and has been shown to have a high detection rate with a specificity of 88.2% if the score is over 20. Now, this is the DEPS-R survey, and patients answer questions on a scale of 0 to 5, from never having symptoms to always having symptoms within the past month. And I'm not going to go over each of these questions, but there are a few that can come up in conversation with your patients that should be your cue to start screening. I would rather be thin than to have good control of my diabetes, or I don't want to gain weight. I try to keep my blood sugar high so that I will lose weight. I feel fat when I take all of my insulin. So really, this should trigger further screening. The DEPS-10, as I mentioned, is a newer, concise screening tool. It's especially reliable in screening for binge eating disorder, and a score of greater than 15 identifies elevated risk. Like I said, it's a really good option for busy clinics and clinicians. The next screening tool is the Eating Disorder Inventory Risk Composite, or the EDRC3. And this comes from the ED3, which is comprised of 2 interviews and self-report. It's a 91-item survey divided into 12 subscales with a scoring system that takes 20 minutes to administer. However, it's not specific to diabetes. The EDRC3 only uses the drive for thinness, bulimia, and body dissatisfaction subscales of that ED3. Your patients only need to have a 4th grade reading ability. This has 25 items and takes 5 minutes to complete. However, it doesn't address driven exercise when patients are exercising either to drive down their blood sugars or specifically to lose weight, laxative, or diuretic abuse, which aren't seen very much in type 1 diabetes or insulin misuse. However, to be fair, the DEPS-R does not assess that either. And lastly, just in a passing mention, we have the Diabetes Treatment and Satiety Scale. This is used mainly in research, which is a 20-item self-report measure. So what happens when a patient screens positive? This is often the most uncomfortable moment for clinicians because we're not trained to deal with it, but it's also the most important. The goal is not to fix everything in one visit. The goal is engaging with your patient. When it comes to managing disordered eating behaviors and diabetes, the person with diabetes has to remain at the center of care. Management works best when endocrinologists or diabetologists partner with dietitians, diabetes educators, and behavioral health professionals who understand diabetes. And by combining metabolic management with compassionate, evidence-based psychological care, clinicians can really dramatically improve outcomes. These are the management approaches, and keep in mind that these have to be done in conjunction with a mental health professional. Cognitive behavioral therapy helps address distorted thoughts around food and insulin. Motivational interviewing supports readiness for change in your patients. Medical nutrition therapy focuses on restoring healthy patterns rather than rigid restriction. And in type 2 diabetes, GLP-1 receptor agonists and dual GIP-GLP agents may reduce appetite and binge frequency, although more data are needed. And keep in mind, we don't want the pendulum to swing the other way towards restrictions. These medications can support care, but they don't replace behavioral treatment. So as far as resources, I found the National Eating Disorder Association website extremely helpful, and I've put the link in there. They have several resources for providers and patients, both for support groups, app-based care, connecting patients with local providers, and I would strongly recommend going on their website and checking it out. In conclusion, so what are our takeaways? Well, disordered eating and diabetes is common. It's under-recognized and it's clinically significant. It often coexists with diabetes distress, psychiatric comorbidities, and fear of hypoglycemia. Yet people with diabetes are less likely to access eating disorder treatment, possibly because of decreased screening, and yet face a higher complication risk. Managing disordered eating behaviors requires a multidisciplinary, patient-centered approach. So if you take one thing back to clinic, let it be this. Unexplained glycemic patterns are often telling us a story, and we have to listen. Screening is not labeling, it's opening the door to conversation, and that conversation can change outcomes. Thank you for watching, and thank you for the work you do caring for people with diabetes.